Good morning, good afternoon, and good evening, everyone. Welcome to another week of Global Cafe. My name is Mitali Mistry, Senior Policy and Project Coordinator here at the IFA. And today I am very excited to be introducing you all to Dr. Roger Knaggs on the topic of understanding pain management and chronic health conditions as part of the three-part series on pain management that is in partnership with Halion. Roger is a clinical academic pharmacist. His current position provides teaching and research opportunities whilst maintaining regular clinical practice. Roger's main research interests focus on the appropriate use of analgesic medicines and associated clinical outcomes and healthcare utilization. He aims to promote the importance of pain within pharmacy and the role of pharmacy within pain management. Roger was the inaugural chair of the United Kingdom Clinical Pharmacy Association Pain Management Group. He is the current president of the British Pain Society after having been a vice president, honorary secretary, a co-opted and elected council member. In 2019, he was appointed by a member of the Advisory Council on the Misuse of Drugs, a scientific advisory committee to the UK government, and is the chair of their technical committee. In addition, he has associations with several other healthcare policy and government organizations in the UK, including the Faculty of Pain Medicine, Care Quality Commission, and NICE or NICE. Roger has chaired the European Pain Federation COVID-19 Task Force since March 2020. So thank you so much today for joining us, Dr. Knaggs.
Hello, Mitali. Very nice to meet you, and thank you very much for the invitation, and also welcome to all of our attendees as well. It's great to meet you all virtually.
Absolutely. So I just wanted to kind of start off by saying, you've had such an illustrious career in pain medicine and management. It would be great to hear what either led you into this work or what has inspired and motivated you along the way.
I think there are two words that really sum up that, and they are serendipity and opportunity. The first, in relation to serendipity, I actually started work in pain when I undertook a PhD in what was around the subject of morphine metabolism, particularly in neonates. And this was in the early 1990s when it had just been realized that neonates experienced pain and that it needed particular treatment. And at that time, I had no idea where my career was going to go. I was in my early 20s, and um, it 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 just so happens that I then ended up in a job um, at the local hospital as a specialist pharmacist working in the anesthetics and pain management departments, which was slightly unusual at the time for pharmacists. And I gradually, over a few years, gained reputation and both regionally and then nationally, and over the last few years, this has become increasingly at an international level as well. And uh, as you said in the introduction, my current role is a mix of both teaching and research within a university setting, but very important to me, I still maintain that regular clinical practice and contact with patients and people with lived experience with pain in our local pain management services. What motivates me? That's a very good question. Pharmacy historically has focused on medicines and appropriate use of medicines, but one of the things that intrigued me about pain from my early introduction to the area was very much around seeing it as more than something that, or a condition that required medicines. And so needing to understand more about psychology and also to some degree sociology as well, because pain has evolved over such a long period of time, and it is something that we all experience. And so it's really important that we try and manage it in the best way possible.
Absolutely. Thank you for that. I love those two words, serendipitous and opportunity. I mean, I think if you ever come across those, I think it just results in something really fantastic in your lifetime, and as it has for you. And I really love that you've kind of already spoken about this intersectionality of pain itself and, incorporating all these different aspects of our lives. It's important to have
Mm.
that consideration. Absolutely. And so, to kind of start our conversation a little bit more on pain management and chronic health conditions, could you speak on the difference between chronic pain and acute pain? And within that same vein, could you discuss the range of chronic pain conditions?
Yes, of course. Maybe the easiest one and that people relate to is acute pain, because as you just mentioned, it is something that, or a sensation that we all, or almost all of us, experience um, uh, at some point, and most people maybe every week, maybe once a month, maybe uh, more frequently that. And it was really developed from an evolutionary perspective as a warning sign within. So it's the brain telling us it's a warning sign that there has been some form of tissue injury or tissue damage. And the experience of pain is meant to be or it's our natural response to try and promote that healing process. And acute pain, because it is generally associated with some form of tissue injury or tissue damage, tends to be localized, and the intensity of the pain is very often related to the degree of tissue damage or the injury. So somebody who has had a relatively minor surgical procedure is going to, such as maybe a hernia repair, is going to have less pain than somebody who has just had a joint replacement. So it very much depends upon the degree of injury and tissue damage. And treatments for acute pain generally are relatively effective. Whereas chronic pain is a condition in which the body's pain detection systems are either damaged or functioning in a way in which they were not intended to. So, using that analogy that I just described in terms of surgery, it's pain that lasts beyond the expected time of tissue healing, which generally is considered to be to 3 months. So pain that lasts for greater than 3 months, it would be what we would class as chronic pain. Colloquially, in some areas, pain or people might say that their pain is chronic, but they don't. That doesn't necessarily relate to intensity. It's more the impact that the pain that is having them. But from a medical perspective, the difference is really in terms of duration. And chronic pain is often more widespread than acute pain, and very often treatments are less effective than they are for acute pain. I think that's something that we'll come back and talk a little bit more about. In terms of types of chronic pain conditions, certainly the most common types of chronic pain that are seen both in community and primary care settings, but also within more specialist pain settings, are musculoskeletal pain, particularly spinal pain, and that is generally low back and neck pain, or osteoarthritis. Or these are conditions that are become more common as we age. But there are other types of chronic pain, such as neuropathic pain, where the pain processing pathway is damaged. So conditions such as there's a complication of diabetes called diabetic peripheral neuropathy, or post-herpetic neuralgia after somebody has had an episode of shingles, are examples of neuropathic pain. And then there's also a group of conditions called nociplastic pain, where the problem is not with damage to the pain processing pathways. It's more that they are functioning in a way in which they were not intended to do. So common conditions that would fall into this category include conditions like tension headache, so regular headache, and also irritable bowel syndrome as well. But of course, there are also a range of pain affects all body systems. And so there are chronic headache conditions such as migraine, and also chronic pain conditions that affect the internal organs within the abdomen and the pelvis that we would term as being visceral pain.
Fantastic. I thank you so much for that very thorough, you know, distinction between first acute and chronic pain. It's good to understand, you know, what are the technical differences between that, as well as I know there's probably a lot more to kind of go through, but the range itself of chronic pain conditions. And, you know, it's interesting, for example, like tension headache, you didn't even think about that to consider as like a classification of pain itself. So that's really interesting to kind of understand. So I was wondering if you could also outline how pain can influence physical and mental health in relation to chronic health conditions.
Well, we all know what it feels like when you experience pain. It affects all aspects of your life. And it comes from an old part of the brain, from an evolutionary perspective, that is intended to be disruptive and to attract our attention to the part of the body that has been affected. And just as I was describing in terms of acute pain, that can, in some cases, can be a very useful warning, and is saying to the body, you need to take notice of this. You need to rest. You need the time to allow the body to recover. But with chronic pain, you tend not to be, or it is disruptive in that you tend not to be as physically active. So you become deconditioned. And then when you try and undertake an activity, and that could be maybe something as small as parts of your activities of daily living, so cooking, mobilizing around the house, and because the body becomes deconditioned, that then causes pain when you try and undertake activities, and so it's ends up as being it's sort of almost a bit like a vicious circle. So the pain is restricting your activities, and that then potentially adds to your pain. But pain also affects our emotions and sleep as well, and it can cause low mood and anxiety. And I'm sure that everybody here today can think of times when they have experienced pain and it having an impact on their emotional well-being as well. But equally, the opposite is also true. So when you have a low mood and anxiety, then your pain symptoms tend to be worse. So again, it's this circle of interaction between pain and both physical symptoms and also mental health that play together to really think about how we then we perceive pain, and also the impact that it has on people's quality of life, and not just has impacts for the individual, but also their relationships with others, and more widely as well.
Yeah, thank you for going through that and just kind of reiterating how deep, you know, pain can really run through, you know, just all the different aspects of your life for sure. I was wondering if you can discuss the role of medications themselves on managing chronic pain.
Of course. So I think the first thing to say is that um, medicines are really just one treatment option for managing chronic pain. And there are a range of different medicines, ranging from some that are going to be freely and readily available over the counter, or in other outlets such as supermarkets and garage forecourts, to those that are only available on prescription, and then those for where there are increased concerns around the potential for misuse and addiction, then the prescribing requirements may well be greater, and restrictions for these medicines are significantly greater than others. And in order to work out which medicine is going to be best for a particular type of pain, it's really important to try and understand what has been the trigger, what the likely mechanisms of the pain are, so that together with healthcare professionals, the person can decide what is likely to be most most effective, and obviously that is then the medicine to try first. However, it's important to put the use of medicines into context with other treatment strategies as well, such as things that you can do for yourself in terms of self-care and self-management, in terms of trying to ensure a good sleep pattern, exercise, as we've just talked about. Increasingly, the role of diet on pain is becoming apparent, and so having a healthy, balanced diet can be helpful in managing chronic pain. Exercise in all forms can be beneficial for chronic pain, and I think again that is perhaps a myth, that actually because I'm experiencing pain I can't exercise, but actually exercise is both from a strengthening perspective, but also an aerobic perspective, very helpful. And then also a range of psychological approaches, such as mindfulness, cognitive behavioral therapy, or some other newer variants such as acceptance commitment therapy, are all types of treatment. So it really puts medicines into just one part of that treatment strategy.
Yeah, thank you so much for detailing that and kind of how it fits into, the comprehensive whole treatment or management of pain itself. Are there any misconceptions on the efficacy of medications for the management of chronic pain?
In asking that question, then quite clearly, then the
Yeah.
answer is yes. And I think the first misconception is that, and certainly in the UK, medicines are often analgesic medicines or pain relieving medicines are often described as painkillers. And so the first misconception is that they don't kill pain. But they aim to enhance parts of the pain process, the body's natural pain processing pathways. So they're much more about relieving pain rather than actually killing pain. And whilst medicines are generally effective for acute pain, as I described a few moments ago, medicines are much less effective for most types of chronic pain, certainly by themselves, with only around 1 in 4 or 1 in 5 people achieving significant pain relief with a particular medicine. And then, of course, even if they do appear to work in the short term, so maybe over several weeks or several months, that doesn't necessarily predict how effective they are going to be over much longer periods of time. One of the issues that we have from a healthcare provider's perspective is that when new medicines are developed, the trials that are undertaken only need to be of 3 to 4 months. So that and so they don't necessarily give any indication as to what is going to happen over longer periods of time. And it's only when medicines are then used more widely, and shall I say, in the real world as opposed to the trial setting, that actually we might become aware of harms and risks that we might not be aware of within that trial setting. So it's really key that there is regular review and assessment to ensure that medicines are doing what both we as healthcare professionals would like them to do, but equally the person who is taking them as well. And at the moment, we don't have a particularly good way of working out who is likely to respond to a particular analgesic or pain relieving medicine. So it may seem a little bit like trial and error. And just because one medicine from a particular class of medicines, whether that be the anti-inflammatory drugs or whether that be the opioids, it doesn't, just because one medicine doesn't work, it doesn't mean that another medicine from the same class is not going to work. And unfortunately, at the moment, that means that the only way to try and deal with that is to actually try a range of medicines. But also it means that we need a range of medicines to be available in order to allow us to uh, to try and find a medicine that works for a particular patient.
Yeah, absolutely. So there is that aspect of having to go through a little bit of trial and error in order to figure out what exactly is going to be efficient for that person, and what might be efficient for one person might be not be for another
In,
person too, right?
Indeed, that's right. Yes.
Absolutely. So if we take a closer look at the challenges of pain management in relation to the concept of polypharmacy and its impact on older adults, what can be said about the issues related to patients that might be taking multiple medications for chronic conditions that they might be facing?
So, as everybody here today will be aware, as we age, we tend to have develop more medical conditions, more medical problems, more medical issues, and so tend to be prescribed more medicines. And the older we are, the more medicines we are very often taking. And I think polypharmacy can have several meanings in terms of analgesic medicines. The first one relates to what I would describe as rational polypharmacy. And I'm particularly thinking of there where combinations of pain medicines are actually used to help manage pain for an individual person. This is very commonly used because the medicines are actually working on, if it is truly rational, are working on different parts of the pain processing pathway. So with the aim of providing, shall I say, the best pain relief with the fewest side effects. And sometimes it can be possible when using this rational polypharmacy that lower doses of each of the medicines may be required, and hence people do experience fewer side effects. The other area of rational polypharmacy I would describe as when there is another medicine that is being used to treat a side effect or a potential side effect that is associated with the pain medicine. So, say when you're taking an anti-inflammatory drug, to particularly as we age, to take a medicine such as a what we would describe as a proton pump inhibitor, such as omeprazole or lansoprazole, that helps protect the stomach and reduces the risk of ulceration and bleeding, or potentially the use of laxatives when somebody is prescribed an opioid medicine as well. The other big area of polypharmacy really comes with the comorbidities or other conditions that a patient might have, or the medicines that they are then prescribed in order to treat these conditions. And this may then limit some of the choices that we have available to us for use of pain relieving medicines. Perhaps one common example would be the use of some antidepressant medicines in people who have either cardiovascular disease or heart disease as well, because they increase the risk of other of side effects on these organs as well.
Yeah, fantastic. Thank you for taking us through that. Polypharmacy is quite an interesting concept. So I think I want to open up the floor now to all of our participants. We've already got a few questions in the chat here. So I'm going to start with a question here from Anna Maria. Anna Maria, if you're here, would you like to unmute and ask your question? Not sure if she's here. If not, I can go ahead and read the question.
Do.
So she's asking, what are the
Yeah,
side
it's not,
effects?
I don't
Oh,
know what's happened. There was a message in the screen. Thank you very much for your presentation. A lot of insights, food for thought. And my question is, what are the side effects of taking non-steroidal anti-inflammatory drugs or NSAID for acute severe pain, chronic pain? Because not all medication are the same, we know that. But I will say I'm more concerned to those who may create dependency because they have the opioids. So that's
Yes.
that I consider to certain point dangerous. But sometimes as a patient don't have other alternative but take them because our body react better to them.
Indeed. So the side effects of the non-steroidal anti-inflammatory drugs, I normally think of as describing them in four different categories. The first one I alluded to in a couple of minutes ago, and that is the risk of problems with the stomach
Yeah.
and small intestine, and they potentially cause ulcers and have a increased risk of bleeding from these parts of the digestive system. The second organ that they affect is the kidney, and they have ultimately they have an effect to reduce kidney function, and so certainly, and as we age, one of the things that happen is our kidney function does decline, and so it is certainly something to be mindful of. They also affect the amount of salt and water that the kidneys are able to eliminate and get rid of, and this can cause two effects. Firstly, it can cause a slight increase in blood pressure, a few millimeters of mercury, but also it can cause the accumulation of fluid, edema in various parts of the body as well. The third area of body system that they affect for some people is the airway, and particularly for people who have a history of asthma, they can they cause spasm of the muscles within the airway. That's, as I say, that's a particular problem for people who are asthmatic or have other respiratory conditions. And then the other area is a more generalized increased risk of bleeding. And this is because the platelets, one of the blood cells within the blood circulation, are less effective, and the platelets are important in forming a clot when we bleed, and so that there is an increased risk of bleeding as well. So as you say, they don't tend to cause issues with dependence and addiction like some other pain medicines, and whilst they are certainly not what we would describe as contraindicators, in other words, shouldn't use them, definitely shouldn't use them in in older people. They should be used with more caution than in or people of younger age, and are perhaps best used for short courses or periods of time rather than being taken over long periods continuously. And also, as I alluded to ensure that you are taking a medicine to help try and protect the stomach as well.
Thank you very much.
Thank you so much for your question, Anna Maria, and thank you for your answer. We have a next question here from Shmuel, which is an interesting kind of departure from what we've been talking about. But he asks, how, according to you, how can AI technologies support improvement in management of different types of pain? Or have you actually seen anything being utilized right now?
I haven't seen AI specifically, and if you don't mind me giving a political answer,
For sure.
because I think as I alluded to actually when describing pain and the impacts that it has, that AI is it, in terms of medicine, there are lots of advances around its use in diagnosis, but actually there is a lot of, shall I say, interpersonal relationships and interaction with other people that are required in terms of pain. And however, in terms of, shall I say, novel treatments, one emerging area where there is a lot of interest is in the use of virtual reality. So it's not AI, but it's a different type of novel treatments that are very technological. But it's still very early days for these sorts of technology, and no doubt it will be some time before we actually see them being used much more routinely. But I think it's certainly an area to watch.
Yeah, absolutely. I think it's quite interesting, but it does come with a lot of, things that you can't really mimic from like the human experience of having, for example, very, interdisciplinary team of healthcare professionals, things like that. So that might be difficult to incorporate, but yeah, we'll see kind of how that field expands. We have a question here from Brendan Sherlock. Would you like to unmute and ask your question?
Thanks very much. Yeah, it's a bit of an odd one. If you get shingles, can that affect I would think the stomach muscles? Because then the problem is, can you get a hernia as a result of the shingles because the strength is not there? I know it's an odd question, but and then is the shingles vaccine any good if you have shingles? Thank you.
Okay. I don't think I'm going to be able to answer your question, the first part of your question directly, shingles by its very nature affects a particular part of the body because it's caused by reactivation of a virus that is stored within the spinal cord. So it depends upon the area of the spinal cord that has been affected. So if the area of shingles is in the abdominal area, then it may be possible that some muscles start working in ways or doing things that was not intended to. But if it is in a completely unrelated, if the shingles was in a completely unrelated part of the body, I'm struggling a little bit to see the link. Does that help to some degree?
No, that's fine. Thank you. Yeah, it's interesting you say that the shingles is in the spine, that's where it comes from. Am I correct in saying that?
Yeah, it's in one of the nerves. Yeah, the nerves that are around the spinal cord.
Yeah, and if I can indulge, the pain, when you get pain, is the pain transmitted by the nerve to the brain, or how does that work?
Yes.
Thank you.
Yes. So or on several occasions, I talked about a pain processing pathway, and the pain starts in, well, if it is acute pain, in the area of tissue damage or where there has been some injury. So it's going to be in a particular part of the body. And then there is one nerve that, or one specific type of nerve that detects that tissue damage. And there are different types of nerve that detect different types of sensations. So whether that be heat, whether that be cold, whether that be pressure. And that is then transmitted to the spinal cord. And then those signals in the spinal cord then go up through the spinal cord to the brain. And then to make it even more complicated, there are some nerves from the brain that go back to the spinal cord. And it's what is sometimes described as a bit of a gate, so that the spinal cord can switch off some of those incoming signals as well. Going back, if you don't mind, going back to your to the second part of your first question around the shingles vaccine, then it is very effective in reducing the chance of you experiencing shingles and then potentially developing other painful conditions. And if you've already had it once, that does not mean that you won't get it again. So the vaccine can still be helpful.
Thank you so much for that question, for your questions, Brendan, and thank you so much for those answers. It's really good to know. Absolutely. All right. Let's see over here. Dr. Rao has some questions, some interesting ones. I think the first one I'll address is if strength, exercise, and vitamins are helpful, I think with pain management. I think you kind of briefly mentioned that already. If you have anything to kind of add with that, maybe in reference to maybe vitamins. I think exercise you did mention being very helpful.
Yeah, I think, and although we have largely focused the discussion on the role of medicine so far, but as I said, there is certainly an increasing understanding of the role of vitamins and other supplements in managing pain. There's one vitamin that does stand out and is worthy of a little bit discussion is vitamin D, so the sunshine vitamin, and the evidence, although it has been suggested that if you have a low vitamin D, then you are more likely to experience pain, or your pain may be worse. Although actually, when you look at large or putting evidence together from different trials, this is a little more uncertain. So, but there are a range of supplements that I know that some people do suggest that they may well either help prevent pain or help manage pain symptoms, such as turmeric, and so a whole host of other substances that are not vitamins, but actually dietary supplements that may well be of benefit for pain as well.
No, all right. Thank you for that. And then there's also a question here from Mark Venning. Mark Venning, if you would like to unmute and ask your question.
Yeah, it's a simple one about acupuncture and its effectiveness over the long term, and for what pain areas does it work or not?
That's an interesting. We could probably spend several hours discussing the benefits of acupuncture. It's been very interesting to watch how acupuncture has been used in the management of chronic pain within the health service within the UK over the course of my professional career. And you asked a very specific question about the longer term benefits, and I think it would be fair to say that actually there is a real dearth or lack of evidence of long-term benefit. And when I first started working in pain management in the UK around 20 years ago, it was something that we were using increasingly for managing long-term pain, but it has very much gone out of favour, and why? And in part is in relation to your question, because whilst people might feel better for a short period of time, it was never our experience was that it never provided any real long-term benefit. And so we had people coming on a very regular basis, and whilst they might have had some benefit over a short period, it certainly didn't provide any benefit in the longer term. And so in the UK, its use has really gone out of favour in the NHS. That's not to say privately, in private settings, that some people still use it and it still has some benefit. But I think it's an intriguing area, and we could debate. There's a Western philosophy about how acupuncture is used. There is obviously the old traditional Chinese acupuncture, and certainly in the UK it was never particularly, I don't think, either one form or the other. It was somewhere. It was a mixture, and there is probably still an awful lot that we don't understand about how, just like many other treatments, how acupuncture provides pain relief from a mechanistic perspective.
Perfect. Thank you for that question, Mark, and thank you for the answer for that. We also have a question here from Eileen. Eileen, if you wanted to unmute and ask your question.
Thank you very much, and thank you very much, Professor, for an excellent talk. I'm picking up on something you said there a while back. You're talking about the two-way communication, the point of the pain, then going up to the brain, and it has a switch-off valve. And then whether it decides to go back and reinforce it's on or off. My understanding on that is that it's like a kid when you fall and you have somebody beside you and they rub it and say everything is okay. So the brain learns, you ignore it or you go on or whatever it is. What I'm trying to figure out is if you keep training the brain to sort of switch off that pain, especially in peripheral nerve damage, where there's no electrical signals, does it mean that you're increasing something, or how effective is that mechanism? It's really self-learning and training the brain, or is there a mechanism in the brain to override that? Sorry, do you understand? A bit long-winded.
I think I do. Let me try and answer it, and if I don't, then you can always come back. But first, I would like to say how much I like the picture that you have shown. It's a lovely Irish coastal scenery.
Yeah, unfortunately, it's rising sea levels.
At one time, and even I can remember when I was training, that we thought that there was a time when we thought that if the nervous system was damaged in some way, that it was not possible for the nervous system to repair or to change, but it has become very clear over the last 15 or 20 years that the nervous system is what is sometimes is described as plastic, and learning is an extremely valuable and important part of that of learning and about how we adapt and how we and how we manage pain. So you gave initially an example of a young child where they have an accident and they rub a particular part of their body, and that's actually, there's a good scientific basis as to why that then is going to provide some relief. But you were asking about long-term pain and peripheral or damage to peripheral nerves, and the simple answer is yes, it is possible for types of chronic pain that actually it is possible to retrain the brain to not necessarily to say that the pain isn't there, but it is possible to that it has less of an aversive meaning, and so that it then has less of an impact on your daily life and daily activities.
Oh, thank you very much.
Perfect. Thank you for that. And Dr. Rao has a question. I think you kind of already mentioned the fact of like training your brain, but another part of her question is in older age, because of muscles weakening, is there a way for older adults to kind of manage that pain, how to face that pain with muscles weakening?
So I think the first first issue to reiterate is that actually activity and exercise can be extremely helpful, and however small that activity or exercise may be. And I think it is an issue around, as I was just describing, remembering that for many, certainly when we're talking about types of chronic pain, that actually undertaking these activities is generally not going to make your pain, or it's not going to cause more tissue damage. And so what we would describe as a sort of a graded approach. So you're going to have to start in perhaps a relatively limited way, but then over a period of time, you will find that you are able to do more and more. And I like, shall I say, advice about exercise and activity more generally, and not just in relation to pain, that there needs to be two components to that. One is first around aerobic activity, and then the second one is around muscle strengthening activities as well.
Absolutely. And kind of within that same line, I think, Cynthia, you have a kind of a similar question. I don't know if you wanted to add anything to your question over there.
Yes, thank you. It's a very enlightening session. And it really is, the sort of motto of use it or lose it. And I think that what you're really saying is exercise, of course, across the lifespan is important, but especially in dealing with chronic. And you just did hit the nail on the head to say, I think I'd never thought for someone, I have a family member with rheumatoid arthritis, and she never stopped moving. She walked every day, and I know she was in pain, but she kept moving. And I think that has held her in good stead. But I never thought of the idea that somebody would say, well, if I wear out these joints more, they'll cause more pain. So it leads to the sedentary lifestyle, which is just, so I'm saying, I think you answered it, but verify for me that movement at any point and as much as you can do is critical.
Exactly. Yes. I didn't talk specifically about conditions like rheumatoid arthritis when I was talking about types of chronic pain, but quite clearly they are long-term conditions that often develop before you or in earlier parts of your life, and so may well live with pain for a long time. And in order for that pain to have, or to minimize the impact that it has, as you say, exercise and activity are really, really key. And it, it's not, as I've said already, it's not, or in when you're experiencing certainly pain per se, that you're unlikely to do any more damage to those tissues by exercising. But again, and that's a very common preconception.
Thank you.
Thank you both. All right. I think I want to throw in one of my questions as well, just at the end. I don't think there's any others in the chat right now. But this one is a little bit of a departure again, kind of what we've been talking about. But I was actually wondering, how might integrated health and social systems kind of facilitate access to pain management for older adults and those with long-term conditions?
I think this sums up an awful lot of what we've been talking about, really, doesn't it?
Mm-hmm.
In that pain affects all parts of your life, from your daily activities to your emotional well-being to your sleep. And in order to help manage, and so one could say, well, it's actually much more than a true medical problem. And so there needs to be a range of different services and expertise available in order to manage pain. One of the things that people quite often describe when living with chronic pain is how isolating it can be. And so it's not just about providing the medical components of care. There is a social component to this as well. And locally, I can think of a couple of examples that of shall I say, social initiatives that have been very popular. I live in the Midlands in the UK, and over the last couple of years, one of our local football, so soccer clubs, has a community trust, and they've started running weekly sessions for people who are living with chronic pain, in order just to have that time to allow them to come together and to learn a bit from each other about living with chronic pain and what they can do to increase the skills that they have in order to manage it. Another example that has been successful in another part of the UK over the last few years are what has been described as pain cafes, social occasions where people who are living with chronic pain can get together, and that's been very successful in the southwest in Cornwall. But I think as most pain is actually managed in the community, one of the key things and from a health perspective is that there is increased understanding and managing pain using our current knowledge and pain science, using this what we sometimes describe as a biopsychosocial approach. So it's not just the biological, so in other words, what's gone on within the nervous system. It's not just psychological, and it's not just social. It's bringing them all together. And the community and primary care are really the places where this can happen the most within within communities. And then, of course, there are a small number of people who are going to require more specialist treatments, and so there need to be a range and availability of more specialist services where these other approaches have not provided the best relief.
Yeah, I think that's a fantastic way to kind of summarize the entire conversation. And I thank you for also providing those examples that you're kind of seeing pop up in the UK as well. I think that could be useful for anyone kind of around the world to kind of encounter if you are experiencing pain yourselves or someone close to you. I think it's, if it's possible, you can open up your eyes to like different ways of kind of helping manage things. So I think that's a fantastic thing to talk about. I think Eileen just posted in the chat another example that's happening in Ireland for an exercise program. So she has that in the chat if anyone wants to take a look at that. All right. So now that we are slowly coming close to the end of today's Global Cafe, before we wrap up, I would love to hear key takeaways from today's discussion. So I'll give you some time just to gather your thoughts as I will introduce our next week's topic and speaker right now. So please join our discussion next week with Dr. Alexandra Lopez on the topic of European policies and practices for older adults in long-term care. So please join us to listen to that great discussion next week. So I also just wanted to reiterate, we have one more part left for our 3-part series of this pain management series, which has been very exciting to go through. So please tune in. It'll be coming up in November. So we'd love to see all of you there at that time. So now we're back to you, Dr. Knaggs. So in a few sentences, what are some of your key takeaways from our conversation today that you'd like for us to all leave with?
I think the first thing I'd like you to leave with are the differences between acute and chronic pain. And in the interest of time, I will not reiterate what I said at the beginning. I think that medicines can be helpful for some people who are living with chronic pain, but it very much needs an individualized approach that weighs up the benefits and the side effects for that individual. And then the other really key message is that medicines by themselves are probably only going to help a relatively small proportion of people. And it's actually this combination of different treatment approaches, such as exercise, and we just heard that lovely example of a group exercise program, and also psychological and social interventions that are going to support people to live as best they can with chronic pain.
Fantastic. So thank you so much. Before we sign off, I would like to thank everyone again for another great week of our Global Cafe sessions, with special thanks to Professor Roger Knaggs for joining us today, and great thanks to the incredible people working here at the IFA who supported this and every Global Cafe, including Miss Luana Colnago. So thank you, everyone. We hope to see you all next Friday, as well as for that 3rd pain management session happening in November, and wish everyone a great weekend. So take care. Thank you.
Thank you.
Thank you
Bye-bye.
so much.